Perfect. Thank you. So welcome back to our series on understanding the health needs and health inequalities of different community groups based on the new community health profiles for 2024 live now on our web pages. We've got a couple of things to go through today in our agenda, and there will be some interactive parts of the session. So it's not just me speaking at you for the best part of an hour. So we're going to quickly go through an overview of what the Latin American community health profile is and where we've gotten a lot of this data and information from and how we have categorised this community in this research. Then go through a quick bit of the demographic overview, so in terms of age, gender, geography, things like that, so we can understand our population on a local level a bit more. Then I'll go through the main findings of the community health profile report, and I'm generally going to pick up on one main finding from each section of the report. The full profile has a lot more information than what we can cover today, but as we've got limited time, I'm just going to cover one key piece of information or one report to stop it being an overwhelmingly large amount of information. Just to highlight that the data that we choose to highlight through each section of the report isn't necessarily the biggest health need or health inequality for the particular community. It's generally just where we had the strongest amount of data that focuses specifically on the community, and where possible in the UK-based surveys and data. For the Latin American population, there wasn't a large amount of UK data readily available. So for a lot of the sections, we have had to rely on international findings, and those should be taken with a large amount of caution, just because it may not be applicable to a UK population based on differences in healthcare services, where most of these studies, for example, come from the US. We'll then quickly cover how to incorporate some of these findings into your practice and what we can do as the next steps following this webinar, and look at those next steps for engagement, as well as having about 10 minutes for some Q&A and some discussion at the end of the webinar. Now, just some very generic housekeeping rules for a webinar. I will just suggest, can everyone please stay muted and turn off any VPNs that you have, just to help things run smoothly. This isn't saying that you have to stay on mute for the whole webinar. If you have any questions or any kind of discussion points, please feel free to come off mute and speak. It's just while we're kind of running through the presentation to help things run smoothly. There should also be several ways to ask questions. So if you want to put your hand up and talk, more than happy with that. But there should also be the chat function on Teams. And we will be using Mentimeter as well, where there will be an anonymous Q&A feature, just in case you want to ask any questions and you don't want to put your name or a face to it. There should be multiple ways that we can kind of engage throughout this session today. All of the slides will be uploaded to the Birmingham City Council website under the specific Latin American profile section, but you will also be emailed the slides after this webinar, hopefully over the next couple of days. And as it's being recorded, the copy of the recording will be available on our Healthy Brum YouTube channel. And again, you'll be notified of when the recording is live. So, as I was saying just a minute ago, we will be using Mentimeter today just as a way of being slightly more engaging throughout the webinar. It's, for those that haven't used it before, it's an online interactive survey type platform where we can ask questions, do surveys, Q&As, all of that kind of thing. You can access it either through your laptop, mobile device, any kind of smart device, and you can access it through either going to menti.com and entering the code 54763171, or you'll be able to scan the QR code on screen, and there should be a link to the Menti in the chat as well. There will be some open-ended questions a little bit later on that may require a little bit more thought and time, so they've just been put in the chat as well for everyone's kind of review ready for later on. The Menti has been set to audience speed, so if there's a question that you want a bit more time on, you should be able to focus on that, and it won't automatically skip you to the next one as we move the presentation along. And you will be able to join the Menti at any point throughout the presentation. That code should stay at the top of all of these slides. So if you've missed the Menti and don't get a chance to join on immediately, there will be that opportunity throughout. So just to get started to see if people have been able to get onto the Menti, we're just going to quickly think about what are we looking forward to learning or discussing today. So what's the main reason that you signed up for this webinar? What are you looking forward to learning? And if there's any kind of key themes that emerge in this, I can spend a little bit more time touching on particular topics if people are interested in one area of health or one aspect of this webinar more than another. Give it just a second longer. If not, I'll just move on and we can pick up the Menti at a later point. Okay, I think we'll move on and we'll just pick up the Menti at the later slides. So a quick overview of the profiles for those that aren't familiar about it. I'm only going to touch on this for one slide because I want to be able to spend the majority of today talking about the specific Latin American community. But for those that aren't aware, the community health profiles are a key set of resources that we've developed at the Public Health Division in Birmingham City Council that look at summarising the physical health, the mental health, the lifestyles, the behavioural and the wider determinants of health-related issues in a specific community. And these focus on going more into that granular level of specific communities of identity in a support away from a shift of using terms such as just BAME to categorise ethnic communities, which often homogenise communities together and overlook huge differences in health outcomes between specific population groups. There is all of the information on the specific profiles can be found on the Community Health Profile homepage, and there is a full Latin American report, which is about, I want to say, 100 pages long. There will also be shortly an infographic summary available, which is just a one-slide overview in case, so that's kind of too much data all at once. It highlights those key pieces of information, and they will mainly mirror what the information that we're talking about today will be. If anyone's interested in the research methodology and how we got the data for these profiles, we've put together a short intro to community health profiles videos, about 20 minutes long, which goes through the databases which we investigated, the search terms that we use, the different the search criterias and the, can't remember what it's called now, but the data validation tools and everything that we use to actually get the data, and the different national data tools and scientific journals that we included in the reports themselves. There is a slight variation in the methodology based on the year that the profile was published, as we've refined this methodology over the years. So the specific methodology for each profile will be in the full report as an appendix item. So that kind of overviewed a little bit about what the profiles are and where this information that we're talking about today is from. I'm just going to cover some of the language that is included in the profiles and which populations this refer to, as the Latin American population, as you can imagine, is quite large and is referred to in multiple slightly different ways. So whenever you kind of see these terms in the profiles, this is generally what it's referring to. So for the most part, the profile refers to the Latin American population, which summarises all countries in South America, Central America, and a selection of Caribbean countries that speak a Roman language. So we'll cover which specific countries this is in a minute, as well as Mexico, which under a lot of data sources is just often classified under other North America. But then there is also terms Hispanic and Latino that is referred to in the profiles. So Hispanic sometimes in the journals refers to anyone with ancestry where the primary language is Spanish in South America, and Latino generally refers to anyone with origins anywhere in South America and the Caribbean. So very similar terms, but when the different journals report on the community slightly differently. The actual data for the most part that we've included in the profile for this population comes from the census, which tells us a lot of information about our population demographics, the geography in Birmingham, and then gives us some insight into other outputs of health, such as general health, housing, education. And within the Latin American population, we typically used the 190 category data set for country of birth, as this was the only variable where we could get information on specific Latin American countries, as there wasn't an available ethnic group, for example, that had this level of analysis available for us to use. For some of these variables, the analysis was only available for the 60 category data set, and this just means that some of the countries of birth have been grouped together. So instead of it saying South America, Central America, North America, having those specific countries, it just says other North America, other Caribbean. The downside to using that 60 category data set is it likely contains a high number of people who are not part of the Latin American community. So we've tried to use that 190 category data set where possible. Now, within those specific kind of overarching groups that I've included on the screen, the countries of birth that were specifically included in each are as followed. So under the South American category included people where their country of birth was in Argentina, Bolivia, Brazil, Colombia, Ecuador, Peru, Uruguay, Venezuela, and then other South America. So a lot of the time in the census, it kind of groups those smaller ones together. Within Central America, this is to find anyone with a country of birth in Cuba, the Dominican Republic, and again, other Central America. That other Caribbean was a category in the 190 data set, but not in the 60, and it didn't give any more information than that. And North America was pretty much just Mexico. So this was the most appropriate way that we could capture the Latin American population, but there are going to be some limitations to using data in this way, which we have quickly outlined on the next slide. So first and foremost, obviously using country of birth data is only going to give us insight into first generation migrants and doesn't explore the difference between first and second, third, fourth, etc. generation migrants, which is typically only going to be applicable to population groups that are recently migrated to the UK, which we'll see in a minute only applies to some of the Latin American population. Additionally, outside of the census, as I said before, there were very limited sources that actually focused on the Latin American population in the UK. And this is partly due to the lack of accurate categories involved in a lot of data collection tools that don't capture the Latin American population in a specific way. So what we've done as well is redefined the demographic data collection tool, which you can find again on the Birmingham City Council website, that has now suggested having a Latin American ethnic group category when collecting information on ethnic group to more accurately understand this population group. Additionally, a lot of the information in the sources, like the GP patient survey and health survey for England, they are unadjusted variables. This isn't too much of an issue in this report, as these data sets didn't actually include any population category for Latin America. So those are some of where we've got the information from and who the population we are defining as in this profile. So we can talk a little bit about who the population is, where they are, and kind of a bit of their geography and the demographics. So in Birmingham, the population size, according to the census, is 3,268. This is likely going to be an underestimate because we're looking purely at country of birth data, so it isn't going to include anyone that is not a first generation migrant. It's also not going to include Latin American populations that have migrated to the UK but were maybe born in were not born in Latin America. So if someone, for example, has heritage from Brazil but was born in Germany, they're not going to be captured in this data set either. So it's likely going to be an underestimate of this population group. With that in mind, the top 3 populations within this subcategory that we see in Birmingham are people born in Brazil, people born in the other Caribbean category, and those born in Venezuela. Overall, in England and Wales, the population size is near on 300,000. And we'll see in geography primarily concentrated in the southeast of England and Wales. When we look at the different demographic factors, so religion, the most common religion is the Christian faith, with about 64% of the Latin American born population identifying with this, which was higher than the Birmingham average, which I can't remember off the top of my head. In terms of ethnic group, there is going to be a significant variation depending upon the specific country of birth. But overall, 44% identified in the white ethnic category, 30% in the other ethnic group, and 20% identified as mixed or multiple ethnic groups. As I was saying, this is varying significantly depending on which specific country you're looking at. So, for example, among the population in England and Wales that were born in Uruguay, 82% identified with the white ethnic group, whereas in the Dominican Republic, 51% identified with the black ethnic group. So there is going to be some variation within this population, purely just because it covers a large geographical area and multiple countries. In terms of the age demographics that we see on screen, again, the age is likely going to be slightly skewed because we're looking at first generation migrants only. So although the Central and South American born population has the biggest population group in the 35 to 49 age category, again, this is likely reflective that second and third generation migrants are going to be in that younger age category that would balance that out. So again, this is likely going to be a slight overestimate. But in general, Birmingham kind of has a younger population than the Central or South American born population. Now, the reason why having a brief understanding of the demographics of a population is useful is if you're doing any engagement with a particular population in a healthcare setting or community health interventions, having that insight of what does my population look like versus who am I engaging with might give you some indication of whether or not you're accurately reaching the full population group. However, as I said, there are some caveats in terms of maybe the age not being fully representative of what the community looks like in Birmingham. Now, one thing I also wanted to touch on, as I was saying, that this profile looks at first generation migrants mostly based on the census data available, that is going to be more applicable to some Latin American communities than others. And we can look at the length of residence in the UK and the year of migration in the UK from different Latin American countries. Overall, we found that around about 44% of those born in Central America and 37% of those born in South America have been in the UK for less than 5 years. So for these population groups, looking at recent migrant data and the census information could be useful, as it will present those findings on recent migrants. But for example, for a community such as those born in that other South American category, only around about 30% of those have migrated in the last 10 years. And there's a kind of a much larger population that have been in the UK for 10, 20, 30 plus years. So just interesting to look at some of that variation. Whereas, for example, populations in Uruguay, which we saw in Birmingham, was one of our largest population groups, almost 80% have been in the UK or have migrated to the UK within the last 10 years. So the international migrant data is maybe going to be slightly more applicable here than it will be for other Latin American populations. In terms of geography, the census mapping tool is a really useful tool to look at populations in a more visual way. If you've not used it currently, I would highly recommend having a little play around. It's a great way to quickly get visual data, but again, it does have some limitations. So for example, we can look at the country of birth data in a visual way using this tool. And for populations that were born in South America, you can typically see that population density increases as we typically go to the southeast, especially around London. The Birmingham population is slightly lower than kind of London and that southeast region, but still higher than some other places in the UK. However, the census mapping tool doesn't give us a breakdown of that geography within Birmingham. So although it shows that 0.2% of people in Birmingham were born in South America, it doesn't show that population distribution, even though that data is available. And we can download that data for the top MSOAs by South American and Central American born populations. For those that aren't aware with the acronym, MSOA stands for the Middle Super Output Area and refers to a neighbourhood of around about 3,000 to 6,000 people, and just give us a little bit more insight on that specifics of where the communities live out in a little bit more of a specific way than just looking at ward or constituency level data. And for the two population groups, kind of overall in that census, the top MSOAs were Edgbaston North, Digbeth and Ladywood Summerhill. So typically in the more so in the centre and the south, slightly south of centre of the city. And for Central American born populations, we've got Winson Green and Gibb Heath, Longbridge North and Moseley Village being the most populated. However, because the population sizes are quite small as well, it doesn't necessarily mean that there's hundreds of people in each of these MSOAs. It can sometimes be less than 100 that these populations have picked, that the census have picked up on here. Now, it's useful to know the geography of a population for doing place-based community events or health interventions to know where the population is based around the city. However, it's important to note that the places where people live may not necessarily be where the community engages. So it's really important to use that mixture of that data-led approach on the population sizes across Birmingham and also that community intelligence of places where communities are likely to engage. So that is a little bit about who our population is. So we've got a couple more Menti now as well to understand where we're kind of currently at before we look at the specific data throughout each section of the report. So I just kind of want to know with the people in the room what your current kind of position is on how you currently use health inequality data to inform your work. The answer could be not at all, and you're using this as a start point, and that's absolutely fine. But it might be useful to kind of share some ideas with other people in the room of roughly where our knowledge is kind of sitting at the start of this webinar. And then we're also going to kind of do a little quick ranking activity of where our knowledge is before we go through some of the statistics versus after, and hopefully we'll see a little bit of a shift towards that higher end. So I'll give that just a second, but if there's not too many answers or none at all, I'll move on in just a second. I think I'll move on and I'll leave the Menti there. As I say, and it is working at a audience pace. So if anyone kind of wants to add to it at any point during the webinar, we can run through it. So I'm going to go through each of the sections of the report and, as I said at the beginning, highlight one key piece of information. due to just the limited time that we have. So the sections of the report in the community health profile closely align with the different thematic areas in the health and wellbeing strategy, titled Creating a Bolder, Healthier City for 2022 to 2030. And it typically follows kind of from birth to death, and then looking at some of those wider determinants of health as well. So it starts off in all of the reports looking at getting the best start in life, which looks at maternal health, and then also information on the health of children and young people in a particular population. So for the Latin American community, we have some information from the ONS on total fertility rate, but then information on maternal mortality and infant mortality is international only here. So again, just take that with some, interpret those with some caution on how it might be applicable to a UK population. So for the ONS data, we're looking specifically again at the country of birth of the mother, and the again, this is only going to be looking at those first generation migrants. And we do have a total fertility rate for Central or South American born women at 1.8 compared to the UK born women at 1.5. What this means is the total fertility rate is defined as the average number of children that a specific group of women would bear if they experienced age-specific fertility rates in a particular calendar year throughout their childbearing years. So in simple terms, it just refers to, on average, how many children someone is likely to be expected to have throughout their lifetime. So a total fertility rate of 4 would indicate an anticipated 4 children for that population group. So it's slightly higher than the UK born population, but not significantly. So it generally is going to be higher for most migrant born populations compared to the UK. There was only 2 or 3 countries of birth where it was lower than for UK born women. And we typically see for migrants to the UK a slight decrease in total fertility rate over time, but this information is not available for the Latin American population. Some of the international statistics that we have on maternal and infant mortality rate potentially highlight a higher rate of maternal mortality rate, of infant mortality rate than the US population, but a lower maternal mortality rate. So we have a maternal mortality rate of 13 per 100,000 live births, and this was for Latino or Hispanic populations versus 18 per 100,000 in the white US population. So there potentially is slightly better maternal outcomes there. But again, this is US based data only, and there's no information on the UK population. And as there's completely different healthcare services in the US, it may be slightly different in the UK, and we may see a difference. In terms of infant mortality rate, we saw international findings that this was highly variable depending upon the specific country that was investigated, and it typically ranged between around 3.8 per 1,000, the infant mortality rate for Cuban Americans, to 5.6 per 1,000 for Puerto Rican Americans. This is on average higher than all infant mortality rates in England and Wales, where the average was 3.6 per 1,000 live births. But again, not sure how this might translate to a UK-based picture. We do have some UK information based on the number of live births. So we can see overall that there was 4,509 births to mothers born in South America and 513 to mothers born in Central America in 2021. So although these are small population numbers, when we considered that the information we have on the total Latin American population in Birmingham, the population size of being less than 4,000, if there's 4,500 live births across England, Wales, UK, you can see that the population may be slightly being more made up of second and third generation migrants over time, but we don't have that information quite there at the minute. In terms of healthy and affordable food, again, this is looking at international data only, other than we have a little bit of information on food insecurity. But one key source that we've used throughout a couple of these community health profiles is the Global Nutrition Report that looks specifically at the overview of national dietary intakes of key food groups or key nutrients in grams per day of adults aged 20 plus in specific communities or specific countries globally. And this provides us a good international insight into dietary patterns, which again may be relevant to migrants to the UK, but may not be relevant to all Latin American populations in the UK. Typically, what we saw in the Global Nutrition Report for Latin American countries is there was a high consumption of food groups like red meat and dairy, And on average, the red meat intake was 495% of the daily target intake, which was 69 grams on average intake per day. And there was low consumption of fruits, vegetables, legumes, and whole grains. So some of those kind of healthier eating behaviours may typically be a bit lower among Latin American populations. So, for example, on average, only 55% of the daily target for fruit consumption was typically met in Latin American countries, with an average of 111 grams of fruit intake per day. Now, there is some information on food insecurity in the UK through a small UK-based study with 170 Latin American community groups that throughout the pandemic talked about how almost a third struggled to pay for their food. And there is typically, we see with most population groups, an increasing of food insecurity in line with the cost of living crisis. And I've also linked the food strategy for Birmingham for 2022 to 2030, which talks a little bit more detail about food insecurity and specific interventions for population groups. So moving on to the active at every age and ability section. Again, this is international data primarily, and there is a bit of a variation in the physical inactivity rates, again, looking at specific countries, and it's not kind of uniform across all of Latin America. So there was a systematic review that looked at physical inactivity rates among Latin American populations. And physical inactivity was defined as anyone doing less than 30 minutes of moderate intensity physical activity on at least 5 days every week. And moderate intensity exercise is anything that raises the heart rate. So a brisk walk or a cycle would be classified as moderate physical activity. We typically found that 43% of the population that was aged 15 or over was inactive, but this is from 2012. But those rates varied significantly from 16% in Guatemala to 68% in Argentina. So big variations in the physically inactive population. And in comparison, in 2021 to 2022, 26% of people in the West Midlands were physically inactive. So we could see that potentially people that have migrated from Argentina may have much larger rates of physical inactivity compared to the US-born population. There was also a study which investigated migrants, Latina women migrants to the US and the impact on their physical activity upon migration. And this study looked primarily at those born in Mexico. So this was 83% of the total population group, and looked at those specifically that were overweight, and found that typically the population overestimated their self-reported physical activity rate. So 36% met physical activity recommendations based on self-report by saying, yes, I complete this amount per week. But actually, when they were being tracked on the physical activity, only 21% met these recommendations. So it's important to note that how the physical activity was recorded may significantly impact how the physical activity rates of a population is presented. It also showed that the number of years that they had migrated to the US for was positively associated with an increase in physical activity. So we may see similar trends in the UK, but again, we'd need more data to confirm on whether or not physical activity increases or decreases with length of residency in the UK over time, and whether or not physical inactivity is higher amongst those first generation migrants than second or third, etc. Now, we have some UK-based data in the living, working and learning well section, primarily focused here on housing and housing deprivation. This is looking at England and Wales. There was no Birmingham specific information, but it is UK-based here. And it typically found in the census that 25% of the South American born and 17% of the Central American born migrants lived in deprivation under the housing domain, both much higher than the England and Wales average of 9%. In the census, housing deprivation was defined as any household that the accommodation is either overcrowded, it's in a shared dwelling, or has no central heating. But there were also several other metrics of housing deprivation that were measured among the Latin American population that can be seen on screen. So in terms of that overcrowded households, we do see this reflected within our population groups, that 19% of the South American born and 10% of the Central American born population in England and Wales lived in an overcrowded household, compared to only 6% of UK born households. There was also a large portion of the population that lived in private or social rented sector housing. So 58% of the South American born and 51% of the Central American born population in England and Wales lived in private rented accommodation, compared with only 21% of the England and Wales average. Now, there isn't specific data on private rented sector and deprivation in the Latin American population, but we do have data to show that renters in the private sector on average spend a high proportion of their household income on rent compared to other tenures such as owner occupied. And there is a link between that private sector housing and poor housing quality. So as the population group is pretty high in the private rented sector, there may be some comparisons that can be drawn there. We can also look at the areas of deprivation. There is a mixed kind of data here on the populations living in deprived MSOAs. So among the top 10 neighbourhoods in Birmingham for South American born residents, when you align it with the 2019 Index of Multiple Deprivation, the deciles were pretty ranged. So it ranged from 1 to 7. So what this means is a score of 1 shows a neighbourhood that is in the top 10% most deprived nationally, whereas 7 would be in the 70% most deprived nationally, or overall we'd say that's a not very deprived area. And there wasn't a consistent score of kind of 1 or 2 or 7 or 8 of Latin American or South American born populations. So there is a bit of a variance in the areas that people live in. However, the area, if an area is deprived or not deprived, doesn't necessarily correlate with whether or not the population within that geography is deprived. So when we can now move on to protect and detect, there was also some smaller UK-based studies that looked at access to particular health and social care services. In this instance, there was Health Watch that looked at the uptake of GPs and dentists in the Latin American population in London. It was a small population study that only had 29 participants, but it found on average that there was large portions of the group, so a fifth were not registered with a GP and 40% had not seen a dentist in the UK. And there was a heavy reliance on migrant organisations for a variety of advice and support needs instead of using those mainstream services. There was a couple of barriers as to why the Latin American population identified that they weren't accessing these services regularly in the UK. And some of these included the language and the limited English proficiency and not having the availability of translated information or translation services, the difficulties in registering for GPs and other services through either not understanding how to sign up, what the services available were. So really important when we're talking to recent migrant populations that we clearly explain what services are available, what the healthcare offer is in the UK, and how to register for these services, as it's often different to a lot of countries' international health and social care services available. And there was also limited understanding of where to seek out this information in the first place. So where to go on the NHS websites, for example, where to actually understand what information and what services were available to the specific population groups. Now, finally, looking at ageing and dying well, there was, again, very limited information on the older Latin American population in the UK and their health and well-being. But there was a US-based study done by Alzheimer's Association that looked at the prevalence of Alzheimer's and dementia among the Latin American population and found on average that the community was around about 1.5 times more likely than those from white US ethnic backgrounds to have dementia. The understanding for this observed inequality is unclear, but there is some overlaps between migrant populations in the UK and experience of things like dementia, based on some of those kind of social impacts, so increased experiences of loneliness and isolation and kind of not being involved in social circles, not being able to kind of stimulate that brain activity on a regular basis may be something that contributes to this. However, there isn't any data to kind of say specifically why there was that association found within the Latin American population. There was also across a lot of the different studies and across whether it was US or UK based, that there was barriers to seeking dementia related healthcare and other healthcare and services based on experiences of discrimination, which may be kind of a barrier, not just in dementia services, but all services. Again, this is in the US, but so there's no comparison to, there's no data that 100% says that Latin American populations face discrimination in UK healthcare services. But it's likely, as we see this across most population groups in the UK, especially in migrant populations, that they do experience some levels of discrimination when accessing health and social care services. So the community health profile overall, as I said, this has provided just kind of a summary start point to start building those co-produced solutions. And it's not going to be a fully inclusive document that will accurately map the experience of all Latin American people. As I said as well, there are some significant limitations to the research that we currently have at the minute, mainly being the reliance on international studies and the current lack of specific category for Latin American populations in a lot of the demographic questionnaires within the UK. There was also some other key inequality data that I haven't had time to discuss today, just based on this being a 1-hour webinar, that I would highly encourage you to go and read the full report for, that also looks at things like experiences of pollution in the city, risk factors for certain diseases such as cardiovascular disease. And it's also one thing I want to highlight, that when we look at the intersectionality, there is going to be compounding health inequalities. So, for example, those that are Latin American with a disability or long-term health condition are likely going to experience worse health outcomes in all of the areas discussed than Latin American populations without a disability. And this can be associated with a lot of factors, so gender, age, sexual orientation, etc., that may influence the population's overall health and well-being. So hopefully kind of this provided a good start point for some of that understanding. So now I'm going to briefly cover the opportunities for engagement, kind of where we can go following this. So I think I'm just going to kind of skip through this one, please, Alex. So where can we go from now? So at the minute, the profiles are all currently in their draft version, and we highly encourage everyone who attends these webinars or who is aware of these profiles to read either the full report or the section of the report where they work most closely in. So for example, if you work in the mental health field, to go and read the mental wellness and balance section of the report. And we encourage, if we've missed out a particular research article or journal article or a piece of evidence that you think would be useful to include in a population based on your own experience of working, particularly with the Latin American community, then we'd be more than happy to have a discussion to include that there. We also want to highlight that all of the profiles follow the same outline template for the specific sections and subsections of health data that we included, just because if there is so many different areas of health and well-being that we needed to take that standardized approach, or as these reports would be twice as long as they are. However, if there is a particular health need or community identified area of importance that's not been included in the final report, then again, we're happy to have that conversation offline to discuss what is important to the community and how we can include that in a way that would influence healthcare decision makers to change services based on those areas of importance. If you also work with Latin American populations, either in Birmingham or nationally, please reach out to us so we can add your organisation details to the report as a signposting for those that want to work closer with the specific community group. Now, there are some opportunities for engagement following this webinar on sharing the profile and potential ways that we can use the profile and the findings in our work going forward. So, for example, sharing the profile, we encourage, if there's anyone that you know within your particular team, wider organisation, or any community organisations that work with Latin American people, we'd encourage you to read the report and share it with anyone who works in these spaces. And some of the ways that we can use the data in the report to influence our work are included on screen, but this is not a summative list. This is just some ideas of what we can do following the attendance to this webinar. So, for example, when making a new project or developing a service or a project proposal for Latin American populations, you can use the Latin American community health profile as a key piece of evidence to support in what particular services are going to be needed, or what particular changes to services are going to need to be made to make them relevant and applicable to Latin American populations. It can be used by those that have that influencing power in particular forums and discussion groups to influence relevant stakeholders to change services and to be an advocate for particular community groups by using this information to encourage services to become more culturally competent and relevant for these different community groups. And if you don't have that kind of influencing power or work on projects on a large scale, just using the information, that knowledge, to make your daily practice more inclusive by understanding what the population needs might be and some of the main barriers faced by the Latin American population in Birmingham and nationally. So we have got some open-ended Menti questions now that were popped in the chat, but you can also work through them in your own time. I'm going to just spend a couple of minutes on each one of these, but if there's kind of no responses in the live part of the webinar, again, you can work through these at your own pace. So the first question that we'll go through, can we go back a slide, please, Alex? is there any way that you envision, I can't say that now. Is there any way that you can incorporate these findings or these insights from today's discussion into your work or your organisation going forward? Again, if there's any kind of opportunities for discussion in the room as well, this would be a perfect time for that. But you should be able to work through this at your own pace. So I'm just going to talk through each of them and leave the questions kind of running in the background. So the next question will be, is there any particular ways that you hope to see the healthcare services become more inclusive and supportive? So this could either be just in general or for the specific Latin American community. And finally, is there anything that we at Birmingham City Council in the Public Health Department that we can do to support improving your work or your practice on the Latin American community? Is there any particular key pieces of resources or information that we could create to support your work in this way? But I'll leave those running in the background and move on to kind of wrapping up the webinar. So we have 11 of these webinars in total. So if you've enjoyed today, I would highly encourage you to sign up on our Eventbrite page to any of the upcoming webinars. So we have 3 more to go on the South African, the Arab and the student populations in Birmingham. And we have also got the remainder of the webinars already live on the Healthy Brum YouTube channel if you'd like to go and watch them. Links of those should be popped in the chat at any point. Thank you, Lauren, I can see you type in. So if you're interested in either those future webinars or the previous webinars, please go and check out those links in the chat. We also have an ongoing evaluation at the minute with the current community health profiles. I can see that neither of the evaluations in the chat, so I'll just quickly skim over this. If there is anyone in the room that has currently used any of the previous community health profiles that are outside of the launch that we're doing this year for 2023-2024, then please take part in this quick survey to just help us understand the nature of the community health profiles as they stand, how useful they are, and how we can kind of improve our work going forward. Now we've got a little bit of time just for a 5-minute Q&A, any discussions in the room. So there is the Menti, I'll leave that up on the screen, but I'll open it up to the room for discussion as well. If there's no questions, I'll turn off the recording and go through some of those kind of key contact information and final links for the webinar. So I'll leave it up to the room now. Is there any questions or comments from anyone in the room following that webinar? I can't see anything at the minute, so I'll stop the recording there and go through the kind of closing statement